Good morning, everyone. Or if you're overseas, good evening, good afternoon. My name is Andrew Spiegel, and I am the Executive Director of the Global Colon Cancer Association, as well as the Chair of the World Patients Alliance. It really is my pleasure today to have been invited to participate in this panel about what has happened as a result of COVID in the cancer community. And we have some really good experts today on the panel that I'm going to introduce in a few minutes. But assuming everybody can see my screen, I thought I would go through some data first. And that data is going to outline what my organization has been able to pull together from some data out there on what impact COVID has had in the cancer community. So as you can see from this initial screen, you can see that this 4-week treatment in the delay of cancer increases the death risk by 10% for all cancers. You can also see on the right-hand side the impact that this pandemic has had for screenings for cancer. For example, for breast cancer, for colon cancer, prostate and lung, we see that screenings were dramatically lowered in the first part of this year. 85% for colon, 75%, 85% for breast, 75% for colon, 74% prostate, 56%. So we know that every year a certain number of people are going to be diagnosed with these cancers. And we know that those cancers are out there. So the fact that people are not being diagnosed with them does not mean the cancers don't exist. It means that people are not getting screened. And we also have some data that I'm going to show you in a few minutes about what the long-term effects of that are going to be. But as you could see here, when we look at the number of patients, the changes in the number of patients in the United States who were diagnosed with cancer before and during the pandemic, we see that in every cancer from breast, colon, lung, pancreatic, gastric, we see that the data ferrets out exactly what we thought, that during the pandemic period, the number of newly identified patients with any of these 6 cancers fell by almost 50%, 46% to be exact. And so this is a really bad thing because we know that all these people have cancer and they're not getting into treatment. And we know that the delays in getting into treatment reduces overall survival of these cancers. So a little more data in my world of colon cancer and in breast cancers. We know that this is the number of people that are going to be diagnosed every single year. And we know that over the next 10 years, as a result of these folks not getting diagnosed with these cancers, there's going to be an additional 10,000 deaths from breast and colon cancer alone over the next decade. And you can see that right here in this modeling, that the people who aren't getting screened right now, their cancers are still growing and their cancers are going to be more advanced stage when they're diagnosed. So you can see that over the next 10 years, this lack of screening for these cancers is going to have quite a dramatic effect. Here's some data from Europe, the impact of COVID in Italy. They found that 500 pancreatic patients, breast and pancreatic patients, missed appointments for chemotherapy or radiotherapy, and they were postponed for 24% of the patients. 64% of surgical procedures were postponed indefinitely. You can look around this slide and see lots of incredible data. Look at the UK that found that 2.3 million fewer tests that helped diagnose cancer had been taken since the lockdown occurred. So, we could give all this data and just keep repeating all the different data that's coming out on COVID, but we know that COVID is having a dramatic effect in the cancer community, from the screening, from the treatment, and from just seeing your doctor on a regular basis. So we did a survey, of course. We represent the nearly 50 colorectal cancer patient advocacy organizations around. And the survey showed things like patients saying, I'm terrified that I might have bowel cancer or colon cancer, but I can't get an appointment. And we've seen some of those appointments being delayed as much as 6 months around the world. People that have cancer, as a survivor, I'm anxious that my cancer's returned, but I can't get diagnostic testing to see if that's true. I can't get in to see a CAT scan. I can't get into the hospital because they're so inundated with COVID. So access to screenings, access to surveillance for those who already have cancer. And then, of course, isolation. Just tell you a little story about my life. My 47-year-old never smoker wife was diagnosed with metastatic lung cancer this April, right in the midst of the pandemic. And we were sure that she had COVID, but as it turned out, she had stage 4 lung cancer. So we've been dealing with exactly all of these things of they didn't want to let me in her appointments with her for an oncologist. And she basically said to the oncologist, I'm leaving if he can't come in with me. But, we were lucky the oncologist agreed. But for a lot of people, they can't go to their treatment with their caregiver or their loved ones. They can't go to their appointments. They can't count on their spouses or family members to take notes and ask questions and, be there. So isolation is one of the things that we're seeing. And of course, as I said, delayed diagnosis, which is going to have some serious implications. We asked, how has COVID impacted your ability to screen for colon cancer? 50% were able to get screened, which sounds good, but that means 50% were not. Of the 50% that were not able to get screened or had a delayed diagnosis due to COVID, 30% have still yet to be screened. And they've been waiting more than 6 months to get screened. 20% have yet to be screened, and they're waiting more than 3 months, but less than 6 months to get screened. 40% had to wait up to 3 months to get screened, and 10% of those individuals had to wait up to 6 months to get screened. So we see these delays are actually happening in real time. So what have we seen in other disease areas? So we're a member of a coalition of international patient advocacy groups that cover ovarian, pancreatic, lymphoma, breast cancer, bladder cancer. Before we joined that coalition, they had done a survey and they reported that every aspect of a cancer diagnosis, from surgery, treatment, follow-up, clinical trials, supportive care, everything has been affected. And for some, treatment has been withdrawn completely or has been altered. We noticed that almost every organization that was surveyed said they had to alter their services for the people with cancer. And so we've seen the online communities really becoming much more robust as people don't have access to their normal support systems. And we've seen that many healthcare provider education services have moved online, or they've actually stopped those programs as health professionals are getting redeployed in critical places around the world. So how can we make a difference? The question for each of you is, are you going to commit to rescheduling a missed screening or a missed appointment? Are you going to ask your loved ones, your friends, and your family to do the same? And if you had symptoms previously and you're still experiencing any of them, will you now schedule an appointment with a healthcare provider to get those looked at? And if you're at the age for screening, especially, I'm in the colon cancer world. So if you're 45 years old or older, or if you have any symptoms or you're high risk, you ought to be getting screened. And will you make this a priority to get screened? Will you take action? And will you reach out? And so we've got a great panel here today, and we're going to jump into that. And it's my pleasure to introduce you to our first speaker, and that will be Dr. Guy Boike, and he is the director of OBGYN at the McLaren Bay Hospital and the Karmanos Cancer Institute. Guy, why don't you tell us what you've been seeing as a physician in this community, in this time of COVID?
Good morning.
There you
go. Morning to everyone around the world. And Andy, that was an excellent introduction with some facts. And as you were speaking, so many of the things that you said, I realize are happening in our practice. So first of all, going back to the original lockdown, we had 30 patients scheduled for surgery. Our hospital locked down all of our office visits and all of our oncology surgeries unless they were deemed emergencies. Our society in a big webinar supported that and said that prognosis was not affected. There was no data for a 4-week delay. We have lots of patients that go for cardiac clearance and whatnot. When we came out of lockdown, we were fully busy. But oncology, almost all oncology specialties are subspecialists, and they are referral subspecialties. So everybody that we see typically go through 2 visits before they get to us. They either see their primary care doctor, then they see a gynecologist, then they see us. So we've noticed coming out that we've had increases in volume for people that were stuck at various phases of that evaluation. That's been one thing. Our hospital has been locked down to family members, which is a really strange situation to operate on somebody's loved one and then call them on the phone, not even in the recovery room, but in their car or back home. And it's been a strange thing for offices. We did have slight delays in referral to chemotherapy and radiation therapy during the lockdown until they got their protocols in place. And I agree with about patients not being able to come to visits. And you're so right, either for elderly patients, their adult children coming in, taking notes or having lots of questions. We are finding that in telehealth visits, we're adding people. We're adding people on phone calls. We're adding them on Zoom calls, because the other part about not being able to come in if you're a family member, if you're trying to be sensible about your exposure to COVID, you might not be traveling much to begin with either. So being able to add multiple people and patients in nursing homes, we're adding 2 or 3 adult children from remote locations on those calls. So it's really stressing the system, and it's an area in telehealth where we really need to explore expanding and get patient perspective and how we can make that a better experience for them. I also agree completely with the comments. A lot of cancer symptoms are intermittent. We see lots of people have symptoms over a year. They come and they go. And so there may be people who had some slight symptoms during the initial lockdown that they don't have now, and they should get in and get screened. The value of screening is twofold. One, for a lot of different cancer sites, it picks up precancers. And precancers can be treated in a much simpler way and prevent cancer. So take pap smears or even mammograms, some colonoscopies, a lot of precancers get picked up. So that's one important thing. They also pick up early stage cancers, which have a much higher cure rate, usually with simpler forms, may not require chemotherapy or radiation, just a surgery. And then I agree completely with cancer survivors who are in follow-up. They should not ignore their symptoms of potential recurrence. So every office, every hospital now has COVID plans. If you're still nervous about going in, call those offices, call the hospitals. Are you screening? Our hospital, they're using one door. Patients and family members that coming in for testing are screened for symptoms, have their temperature taken. All hospital staff are screened for symptoms, have their temperature taken. Surgical patients are tested for COVID. I reassure them that the COVID patients are in one ward that doesn't involve surgery or the post-op floor. Patients that are having surgery are screened essentially 3 times for symptoms, once by us in the office, once by the anesthesia team in the phone call, once when they come in. And if you have symptoms, your surgery is delayed and you're tested. Most offices now screen patients the day before for symptoms, screen them at the front desk and limit visitors maybe to 1 patient. So most of what you have said has been what we've been experiencing. And there are ongoing challenges, I agree. That was an excellent presentation.
Thanks. And next up, we have Guy. I'm sorry, you're Guy. We have Mark Liu, Director of Strategic Initiatives and Oncology at Mount Sinai Health System. Mark, could you tell us a little bit more about what that title entails, what you do at the system, and then tell us what you've seen as a result of COVID?
Sure, and hi, good morning or good evening, depending on where you're tuning in from. Thanks again for having me on this panel on such an important topic. My role is pretty broad. I work on a variety of different initiatives within oncology at Mount Sinai Health System based here in New York City, ranging from clinical quality to IT to for me, kind of personally, it's pretty important on kind of how are you bridging the health equity or divide that exists in the United States, both through just regular in-person care, as well as now with all the telehealth consults that we're doing, that digital health divide that exists with access to technology. So that's a little bit about my role. I think that similar to what Guy was mentioning earlier, when the peak of COVID was in New York, what seems like yesterday, but several months ago at this point, we dramatically changed our safety practices to keep patients safe. So similarly, we continually disinfect all of our areas and high touch surfaces. All of our patients and staff are required to wear face coverings. We follow social distancing protocols. Similarly to Guy, we also screen all of our patients for COVID-19 symptoms the day before their in-person visit, as well as in the lobby when they arrive into our cancer center. And we also regularly test our staff for COVID-19. So we've definitely implemented lots of different kind of precautions to keep both our patients, caregivers, and our staff safe as we continue to provide cancer care during this kind of COVID era that we are currently living in. So in addition to keeping our patients safe, we have a COVID-19 kind of safety code of conduct for our staff. So everyone, myself included, even though I don't see patients, I check my temperature every day. I answer a survey, screening myself for COVID-19 symptoms, and also kind of complete like a self-attestation before I can even come on site. And then if I have symptoms, like, our employee health services have been really helpful in kind of triaging that. And they've installed, and we've changed kind of how we've done business. So they installed, hand sanitizer stations throughout the hospital and cancer centers. And it's been really helpful.
So I have a question. So both of you have talked about the protocols that have been put in place. And it sounds like if I were a patient and I knew that, I might feel a lot better about coming to Mount Sinai, or I don't think I'll ever be seeing an OBGYN, but in the event that I were a patient and I've been hesitant to make that doctor's appointment or come to the hospital, my question is, how do you communicate all of those precautions to the public so that they will act and come back to appointments? So that they'll know. Are you sending letters, emails? Are you calling? How are you getting to those patients so that they know they should feel safe coming in for treatment or for screenings?
Yeah, I can tackle that first and maybe pass it over to Guy. So, during the peak of the pandemic here in New York, my role among many others at Mount Sinai and other hospitals have changed. So I worked really closely with our marketing team, and I have to give them a ton of credit on communicating a lot of that information, I said earlier, and directly with patients and caregivers. So we sent emails to patients. We used, there's an app that our patients use, and our cancer, almost 40% of our cancer patients use this mobile app. So we sent direct messages to them through that app. We've done commercials, radio advertisements to really communicate that information outside of just traditional online multimedia. I think that the headline of the campaign was "Don't Put Your Health on Hold." And we worked really closely with them to discuss kind of the messaging piece for how to not put their cancer care on hold. And how, if reassuring patients that it's safe to get care, and also the new kind of avenues for patients to seek care from us and from their doctor, whether it's in person, a simple phone call, or a video visit.
And have you found, since you all implemented those systems, have you found patients returning? Do you have any data on that?
Yeah, I mean, we've been tracking that volume very closely. It wasn't kind of a flip of a switch, but I think over several months, we've been able to build back our volume to where we were kind of this time last year. which is really encouraging. So, big credit to our cancer leadership and our marketing team to really communicate this effectively to patients. The other thing that we also did that I didn't mention earlier was we did a webinar, kind of just like this, with a bunch of our cancer experts, covering a lot of different cancers. And it gave us an opportunity to speak directly with the public, whether it be patients, caregivers, people who just were kind of engaged in our health system, had some questions and wanted to kind of see for themselves what it was like. So in that webinar, we included pictures of what the waiting rooms look like in terms of, we rearranged furniture, we reduced the number of chairs in the waiting room. We kind of took pictures of what that lobby looks like with all that screening procedures that I mentioned earlier. We took pictures of the dots on the floor of how we're making sure that we're being socially distant. And I'm trying to think of other, and for New York, we were unique that we had tents in Central Park, just so Central Park's like kind of right across the street from one of our hospitals. And during the peak of the pandemic, when we were worried about inpatient space, there were tents put up for temporary hospital beds. And one of the images was they were there, in March and April, and they're not there anymore, right? So I think, kind of helping folks understand that it's an evolving process, and that we rapidly changed how we operated to meet demand, and we also changed back when it was appropriate.
And let me follow up the question on that before we go to Guy. Have you seen any sort of mass messaging from hospital administrators or from any of the professional associations offering guidance to community hospitals or to oncology centers on how to best communicate that? And I know I'm hitting you with this question out of the blue because you work from Mount Sinai, but a lot of community hospitals can't afford to do television advertising and direct mail and things like that. So I'm just wondering, is there anything that you've seen out there where there's sort of standardized messaging that they know works to get patients back?
Yeah, there's so GNIHA is the Greater New York Hospital Association. They're the ones here locally, but they're a lot of like ASCO has guidelines out as well on those pieces. I think there's as we all know, there's not one type of cancer patient, right? So I think a message that resonates with one person may not resonate with another. So I don't think there is no silver bullet in healthcare, right? So I think there's multiple avenues that you have to pursue to reach the broadest audience.
Right. So Guy, I had asked Mark about how his system has communicated to patients that they have created protocols that would make it safe to go back. So what have you seen? What have you done in terms of getting that message across?
Yeah, and this is a different perspective because I'm actually at a small community hospital. Even though our hospital system, McLaren, is a 14 hospital system and all associated with Karmanos. Karmanos Cancer Institute is headquartered in Detroit, which was one of the real hot spots. So they were really overwhelmed. When we first learned that our office was being shut down, it was being shut down the next day. We were in the office. They said, tomorrow you're closed for 4 weeks. That afternoon, I spent 2 hours on the phone with the IT department because we had not done telehealth, and immediately started the next week doing telehealth. My nurse and nurse practitioner worked from home. So our outreach to patients was direct, with patients that were scheduled for appointments or scheduled for surgery, lots of discussions. And it was, I have to say, from patients, it was a real mixed reaction because some patients were so terrified of COVID at that time. They were more terrified of COVID than their cancer. Other patients were more terrified that their treatment was being delayed or the office visit was being delayed. So we saw it on both sides. And it took a lot. So I had direct contact. 2 of my office staff had direct contact with all of our patients. The hospital, in the meantime, developed their guidelines very similar to what Mark was talking about, on how to handle inpatients and subsequently office visits. So it was kind of on, and I didn't personally have a lot of contact with the hospital while we were closed down until so I got a call from my CEO, said, you need to come back to work. We need to get going. But it was devastating from hospitals. I mean, we're a patient advocacy group and talking about that. But for hospitals, my hospital going from 280 patients a day to 70 inpatients. Other area hospitals, I'm in the Tri-Cities of Michigan. Other area hospital went from 280 down to 80 patients a day. It's really hard to maintain hospital services like that. So it was really a mixture of direct reach out to patients. The other thing that you find out when you're making a change so quickly, the change to telehealth, that is a terrifying thing if it hasn't been done by your practice before, especially when you have your office staff trying to work from home to help you work out the bugs. And without an obvious telehealth program, I mean, we had a really lousy program that the hospital had used for psych patients. And I ended up attending, I think, 6 webinars during the 4 weeks I was off, 3 by my society, 1 on telehealth. And it was interesting that the discussant talked about using phone calls, FaceTime, Zoom, Skype, went through all the different video conferencing, and since all those changes that allowed telehealth to be uses to be extended, he said everything goes. We made that change. That made it a whole lot easier. And I'm interested in Mark's comments about the digital health inequities, because I'm finding the same thing. While a lot of elderly patients come in with their iPads and are very used to getting on FaceTime with their grandkids because they're in different states or different cities, a lot of people still don't have internet, or they have to go outside to take their call. Or I've had one patient in Walmart in the checkout line doing her telehealth visit. I've had people in drive-throughs at McDonald's taking my call, and it's something that we're still adjusting to, and it's going to be interesting to see where that ends up, in a year or two.
Yeah. Well, thank you for that. It certainly different perspectives, as you both in different settings. I wanted to throw a question out to the audience. For any patients or caregivers that are in the audience, I would like you to write in the chat box, what would it take for you to get back to care? What would it take? What do you want to hear? We've heard a lot of protocols from both speakers today about what the health systems have done to get people back to screenings and back to care. But what would it take you to get back to care? What do you want to see? So write that in the chat box. And we do have a couple questions already. The first came from, fantastically, a 17-year-old who's taking care of grandpa who's got cancer and feels, I think, a bit out of control or unable to help, and wants to volunteer at the hospital, but can't volunteer at the hospital right now because of COVID. So what would you, Mark, first, what would you say to that 17-year-old that wants to volunteer?
Yeah, so I think, I totally hear where you're coming from. I think I volunteered at hospitals, where I grew up, and it was such a rewarding experience. So I firstly just applaud you for your willingness to give your time to do that. I think part of the reason why you can't volunteer at the hospitals is because we want to keep everyone safe. But I also hear your desire to want to do something, right? And when I think about cancer patients, particularly those that are undergoing treatment, there's something called social determinants of health, and they're actually a big part of what drives outcomes for cancer care. And what it is it's the things that are outside of the treatment itself, whether it's chemotherapy, radiation, or the surgery, that really determine, really great outcomes for patients. And they're just basic necessities, like, access to healthy food, being, housing security, things like that. So, while you can't volunteer at a hospital right now, I know that, there's a food security issue for patients who have cancer, and also for people who don't have cancer. So I think if you want to help, in this COVID era, I think maybe volunteering at a local, food pantry to help, get food to people would be one way to contribute to the cause.
Yep. Great answer. Guy, did you have anything to add to that?
Yeah, I think it's going to be really hard to volunteer at a hospital right now. It's hard to get into the hospital when family members can't get in. It's a wonderful thought. How can I help? If more people thought that way, we'd all be better off. Very commendable.
Yeah. Yeah.
But when the time comes, I started in high school as an orderly in the hospital. That was my first introduction to medicine. My younger brother volunteered in high school, became a respiratory therapist. So for that individual, that may be the beginning of a career in healthcare.
Yep.
I just want to touch on what Guy mentioned earlier about the telehealth piece, if that's okay. So, telehealth, so one of the bright spots of the pandemic was that it really advanced telehealth at least 5 years, right? Because it really forced people to use it, whereas before it was a nice to have. So I think that there's two pieces that came from the pandemic and the emergency use that was super helpful. It reduced a lot of the regulatory issues that made telehealth complicated. So just for example, if I was a physician that was licensed here in New York, but I wanted to do a telehealth visit to a patient that was based in New Jersey, like if I don't have a New Jersey license, I wasn't able to do that. Those regulatory components were under emergency protocol, made they were removed. So, I think that when we think about telehealth for the future, when we're not in this kind of emergency mode, there's some like regulatory hurdles that I think we just need to decide on what that means. And I think to what Guy was speaking to as well, there's like a functional component, right? There's a comfort with technology for the person, for people on both sides of the screen, right? So for the clinician and also for the patient, that I think, all of us have been comfortable or more comfortable with Zoom, whether we liked it or not. And I think that, kind of using this as a launching pad to continue the use of telehealth services in a way that's meaningful for clinicians and patients is super helpful. And I think, one of the studies, so our oncologists in New York do not like to be bored. I think they've done a lot of research thinking about, looking at a digital health equity as well. And one of the things that we noticed was that, minorities compared to Caucasians, they were more likely to use a phone visit as opposed to a video visit. And it's kind of to the point that I think Guy was mentioning earlier, that like they don't have like strong enough broadband access, so they just can't do the video visit and things like that. That really kind of create that digital health divide. So one of the things that through the CARES Act we had applied for funding for through the Federal Communications Commission was to help to apply for funding to pay for remote monitoring devices for vulnerable cancer patients. And what that does is helps us provide real virtual care beyond the four walls of our cancer centers to patients wherever they are. And not just for the device themselves that looks at their respiratory rate, their pulse ox, their temperature. It also has like a little home hub where it's like a hotspot. So it allows us to, whether you have a really great, broadband connection or if you have no connection at all, it creates a hotspot that's paid for through this grant, generously through the CARES Act, that allows us to to do video visits, to allow us to continuously monitor patients' vitals, give them a tablet to do the video visits I mentioned earlier, that you just know a lot more about patients, right, than you would through a phone call. You can see how they're doing. They can show you something that looks, concerning. You also can just see their face, which also says a lot, right? So I'll just pause there, but I did want to touch on the telehealth kind of hurdles that I hope from a policy perspective and from a payer perspective continue to provide the support and the reimbursement to allow for this to really continue.
Yeah, really great points, and really amazing to hear that the innovative, out of the box things that you guys are doing to monitor patients that can't come into the office. So Carla is starting. She's an audience member. She's starting chemotherapy on November 30th. Her family's worried that they won't be allowed to be in there with her. And I had mentioned that we went through this. So we were lucky enough that my wife's oncologist will allow me to go, or her mother to go, if I can't come. But one of the things that we've done is that if I can't go with her to one of her appointments, she FaceTimes me the moment the doctor walks in. And so I'm there virtually the whole time. Even though I'm not there in person, I get to see the doctor. I get to ask questions through FaceTime. Not everybody has an iPhone though. So what would you suggest to Carla and her family, who are a little worried that she's about to start a new chemotherapy? Presumably she's going to be in an infusion center, and she's going to be in a chair getting chemotherapy and will not have a family member with her. So what would you suggest to her and her family so that they're a little more comfortable with this process? And I'll go to Guy first.
I think I responded to her directly. One of the things, as you say, is smartphones, iPads, so that you can have that kind of virtual connection. A lot of family members actually sit in the parking lot in their car or stay nearby. So that's, I think, about the best that you can do. The one thing about telehealth, I think we're at a real crossroads. And as patient advocates, I'm not sure what the next change in healthcare is going to be. Obviously, with the changing administration, will they put all the restrictions back on telehealth, which would basically make it hard to use in oncology? I've noticed the same digital divide. I have patients from different areas in Michigan, and minority patients definitely take phone calls much more than video. And I find those very satisfying as well, and I think they do as well. One of the things about telehealth with regards to chemotherapy and family members, the application of telehealth between visits for chemotherapy is an excellent thing. You reduce the exposure of somebody getting chemotherapy to come into the office. Most, once you set out a plan, whether it's 6 cycles of chemo, 8 cycles of chemo, usually the visit before chemotherapy is to assess side effects and make any changes in those kind of medications, to review lab work to make sure somebody's ready for the next cycle of chemotherapy. But it's not usually an update on tumor status. That may happen halfway through and at the completion if you have CAT scans or PET scans. And I noticed that in a lot of those visits via telehealth, the patient, especially if it's an elderly patient, is at home with their family. So the way that family members can be part of your chemotherapy or even radiation therapy is your telehealth visits in between. They can be at your house and they can be on the calls. But again, on telehealth, I think this is a point where patients really ought to make their voices known, because I'd hate to see and the government in terms of funding telehealth visits, because it would be a shame to see it go away. I know COVID's not going away, but even if we had no COVID, I think this has been a good expansion of healthcare services that we ought to try to preserve.
And Mark, did you have anything to add on that?
I think I covered it pretty well. I'm just going through some of the questions in the chat. it sounds like there's like some questions around, you know, visitor policies and things like that. I think that what we've seen with the pandemic is that it's ever changing, right? And you know, we as healthcare workers, we always adjust to the changing environment. So I think for those types of questions, there's never like a blanket statement because different parts of the country have different approaches and different just where they are with the pandemic, with number of cases is a little different. So I think, you know, calling, just making that quick call to your doctor's office to understand, you know, what they currently, you know, understand firstly what they have in place in terms of precautions, but also, you know, what's the current visitor policy so that you can best support the patient, you know, as he or she goes in for their care. Did want to touch on one thing now that the we're, you know, the peak of the pandemic is a little bit behind us in New York, though we're seeing, you know, rising cases. What, you know, so last month, as many of you probably know, was Breast Cancer Awareness Month. And one of the great things that we were able to reinstate that had to unfortunately be put on hold temporarily was the Mount Sinai mammography van. And it's a pretty, I wish I should have showed you a picture of it. It's just like a big RV type looking thing that has like 3D X-ray technology, similar to as anyone would in a regular doctor's office, and offers breast cancer screenings to patients in all 5 boroughs of New York City. It's funded by New York State, and what's great about it is that it's free for uninsured and also those eligible for under the New York State Cancer Services Program. And it was great to kind of feel a sigh of relief that we're a little bit past the pandemic a little bit by reintroducing this mammography van into our communities. So when thinking about, you know, how do we change our operation to really meet the needs for patients in this COVID era? So we're doing that in person, we're making sure patients are safe, we're making sure our staff are safe and screened to provide that care. We're also making sure that the telehealth services are beefed up enough so that, you know, the providers are supported to do them, as well as the patients being supported to know how to use the technology. But also we're going to patients' communities to really make sure that, you know, they have access to the screening and where we can, you know, at low cost or free of charge to patients.
So much of what you've talked about today is telehealth. And I guess the question that pops in my mind is the big barrier to telehealth was always getting payers to pay for those visits at the same rate that they would pay for in-person visits. And now that in about 2 weeks that was accomplished, something that took here in the US many years of discussion was accomplished in just a couple of weeks. So that's amazing. But the question I have for the panel is, where do we go from here? Arguably, we're now in the second wave, or we're maybe in the first wave that's getting worse. Telehealth is clearly here for the short term, but what do you think about it in terms of the long term? Do you think this is going to be something that's going to stay and be part of clinical practice? Or do you think once the pandemic sort of settles down and people are getting vaccinated and this sort of goes away, so to say, you think that telehealth will go away?
I don't think it's going to go. I don't think it's going to go away, Andy. And Mark can attribute to this. I assume a lot of their patients travel to come for care to Mount Sinai. You know, I'm in mid-Michigan and I have people coming from an hour or 2 hours away. If they're getting chemotherapy, I always find somebody closer in their community. But it's a convenience for patients. And if we're patient advocates and you can provide the same quality of care, one of the things we can do it quicker with telehealth. It's easier to add on a patient with a telehealth visit is necessarily to schedule a physical visit. So I think it's more convenient. The acceptance rate I find is very high. I don't know if Mark knows of any surveys or if you know of any surveys of oncology patients who've had telehealth experiences. I find it as a wonderful experience, and I always thank people for inviting me into their homes. You know, especially with video, and you see I know I've had such wonderful experiences. I'll see a deer head, mounted on the wall, and you ask the patient, I have all female patients, obviously, did you shoot that deer? And they'll get up and they'll take me around the house with all their trophies. Or I had one patient, her husband kept popping his head in, and I said, boy, it looks like you guys live on a beautiful lake. He took his computer outside and showed me they lived on a river, and it was, they just really like it. And it does decrease their exposure. It saves them a lot of travel time. It saves them waiting. If you're running behind, they can still be doing stuff at home. So I hope that the regulations don't change. It would have been impossible to do, as you point out, what we're doing now before the rule changes. And I think it's here to stay. In a webinar in our society, 85% of GYN oncologists said it would be a permanent part of their practice.
Wow. Well, that's really interesting, especially in your field where, you're doing breast exams, you're doing gynecological exams. It's very much so, a hands-on. You have to be touching the patient in order to do your job. Yet you find value in telehealth. And if you find value in it,
well, for people, for a lot of our patients on chemotherapy, they've just had a surgery.
Yeah.
And they've had a baseline CAT scan. And if it's, like I said, if it's 6 cycles of chemo, we might have a CAT scan after 3 and a CAT scan after 6. And all those visits in between don't really need a physical.
Right.
Even some of our pre-op patients, new diagnosis, if I take a woman with uterine cancer that's had a DNC by a gynecologist, and I know all of my referring doctors, there's always an op note with an exam. There are frequently pelvic ultrasounds and CAT scans. So I think and then if you do a telehealth visit and you think you need a physical exam, then you just say, come into the office. We do post-op visits. We do a lot of robotic surgeries. No staples to remove. People go home if they have an early stage cancer. I say, if you have the option, you can come into the office, or we can do your initial post-op visit as a telehealth visit. And if they don't need any additional treatment, they're doing fine. Their next visit may be in 6 months. Some of the telehealth visits are good just to know that somebody doesn't have potential symptoms of recurrence. And a lot of times that's what their visit is for. So you might do one telehealth visit to make sure there are no potential symptoms of recurrence, and then the next one might be in for a physical exam. There are ways to apply it judiciously, I think. And if there's ever a doubt, you have them come in.
And what do you think, Mark? Is telehealth part of Mount Sinai's future, even when this pandemic passes?
Yeah, I think that we've made significant investments in really enhancing how we provide virtual care to patients, and also giving more information to our clinicians, aside from the video visit with the remote monitoring devices that I mentioned earlier. I think, while we enjoy the parity of telehealth from a reimbursement perspective currently, similarly to Guy, I'm cautiously skeptical of, but I hope that they continue the reimbursements in a way that makes this model of care that we all think is here to stay, sustainable and while we can still keep patients safe. I totally echo Guy in terms of the time piece. I think that a lot of what I think about is, when thinking about delivering value to patients, is are we respecting their time, right? And I think what's interesting about the pandemic is that it has really forced hospitals and healthcare organizations to think about, am I making the best use of this patient's time when they're on site? Because every time they come in, every minute they're there, it's a risk, right? And we want to be mindful of that. So for those reasons, I think that we've definitely wanted to make sure that every minute they're there, that we're trying our best to be respectful of that time commitment that they're making. We've actually done, because we're COVID testing all of our patients on chemotherapy and also before their surgeries, we realized the burden, right? To have patients travel to our hospital to get a COVID test, to go back home again, to go back the next day for the chemotherapy treatment. It's a large burden, to say the least. One of the things that we've done is really partnered with our community paramedics to provide in-home COVID testing for our cancer patients. So what that does is prevents them from needing to make 2 trips. And for outside of the time of travel, in New York City, while things are close, it does take a long time to get to and from places. It's also the cost piece, right? Like, it's expensive to park in Manhattan. It's expensive to take a car service. If you don't have a car, I mean, some patients that I've spoken to, it's $150 round trip each
Wow.
visit to the city, right? So if you can save them $150 out of pocket by providing an in-home COVID test to them with skilled paramedics, then yeah, sure, like we'll definitely support that when we think about these new models of care of how we're delivering value to patients.
So the other day I was in the supermarket and I witnessed 2 ladies having quite a little battle. And this leads me into one of the questions from the audience. And I'll ask the audience one more time. We only have about 9 minutes left. What would it take for you to get back to treatment? What do you want to hear from your healthcare providers? What do you want to see in the systems besides what you've heard today? Do you have any innovative, cool, out of the box thinking that we could get back to the professional societies to help you as a patient or a caregiver feel better to get back into screeners or back into treatment? But I was in the supermarket the other day and there was a lady wearing her mask just like this, completely under her nose. And then there was another lady screaming at her that she had a kidney transplant and she was on immunosuppressant medicines, and this woman's going to, and the 2 of them literally almost got into a fist fight. So someone from the audience says, my hospital has protocols in place for employees and for patients, but people aren't following those. Now that, at least in the US, mask wearing has sadly become a little bit of a political statement. And so what do you do with those employees and those patients that don't listen, and the hospitals don't enforce it because they don't want to, they don't want those screaming matches happening in their office. So what do you do, David? What's your policy? Mark, not David, sorry.
Oh, sorry.
Everyone's waiting for David. There's no David.
David's my dad's name, so it's perfect.
If my cousins are Mark and David, I get them backwards.
Yeah, it's
question.
tough. It's tough, right? Because I think that, it's not comfortable. And sometimes when you're kind of suffering or kind of wearing a mask and like it gets a little hot, I mean, it's better now that it's cooler weather, but particularly over the summer when it was like 100 degrees out and humid in the city, it's not fun to wear a mask. I think that, we have a policy where we encourage our employees to hold each other accountable, right? And we kind of create a space where, at least in the workplace, to encourage people to feel comfortable to voice that concern. In the public, it's a little different, right? Because it's kind of like you said, it can go a little, can be a little of a hot topic every now and then. But I think, when I think about mask coverings or just getting people to seek care, which I think is the point of this panel too, is all that being said, we can message, I can speak till I'm blue in the face, and we can message through mail, email, app messages, everything. At the end of the day, the people in the audience, you are our best ally. I think that, people listen to people that they know and people that they trust. And, organizations can put like an ad in Times Square and, people will just walk by it. Whereas if you know someone, a family or a friend telling you, hey, you're due for your, mammography, you're due for your colon cancer screening, hey, I'm a cancer survivor, please, like, make sure that you get your screenings done. It saved my life. Those are the types of messages that I think are the most powerful. And, I strongly encourage, folks at this conference tuning in and the advocacy organizations to really work with your with the people, with your communities, to encourage people to seek care in a way that's safe for them. And I think that is really the ultimate message here. We're here to, we're creating safe environments. We're here to provide the care, and our cancer center is 24 hours a day now. So, we are available and open for business. I think what it is that, we want to really, you are our best ally. And I think, trying to communicate that to the broader group would be really helpful.
Yep. Any thoughts on that, Guy? Because I have another question for you after.
Yeah, trying to get people to wear masks is a hard thing, but I think for individuals, if you see somebody for a mask, if you just say, would you please wear a mask, would make us all feel more comfortable. It's terrible to watch people get in fights over stuff like this. And I can tell you, over the summer, even in my local grocery store where they had signs, I'd go in and there'd be a group of people that would come in without mask, and I would stop and ask the manager, and he had his mask down below his nose like that.
Yeah. Yeah.
And at the time, and I'm in Michigan, so we were a pretty strict state. He said, well, no, those are more suggestions than mandates. I said, no, not really. That I read the thing, and as time went on, they became a little bit more stringent about it. I recently flew to Arizona. And the airlines are very strict on masks. My daughter was in a different row, chose not to sit with us. I don't know why. And she said the three people around her had their mask off all the time. And she came up and complained to us. So she's really taking it very seriously. I said, well, tell the stewardess. And I think they asked him once to put it on. They didn't enforce it. I know standing in line in the airport, there was a person from the airline that would walk around and tell people to put on their mask. But what's lacking, have you heard a politician on either side encourage people to get back in for their screening?
No.
And there's a lot of scaring people. Even when there's good news about survival and new drugs and stuff, I haven't heard anything about, we need to be sensible, but there are some things that in medicine that need to go on. So that would be a nice thing to hear too, whether it's local or national.
It would be great to see a national campaign getting people back into care, run by,
Where's the American Cancer Society's public service announcement?
Yeah.
Maybe that we should target. We should send a big letter, lots of signatures.
They may be on, who knows, right?
Yeah, state the importance of getting back to screenings, yeah.
Yeah. So we're just about out of time. And I do have one more question, which came from the audience, and this is a question for Guy. I'm old enough to remember when there were about 8 channels to choose from on television, and one of the shows was Marcus Welby, MD. The youngins out there won't remember Marcus Welby. Yeah. But I'm not old enough to remember home visits from doctors, but I remember the show well, that Dr. Welby was a home visiting doctor. He, back in the day, there were no doctor's offices. The doctors went to the houses, and a couple of our audience members love that idea. Do you think that's going to come back, Guy?
No. and I remember the show very well, and he had a young partner as well.
Yeah.
But I think video telehealth visit is a lot like a home visit. I mean, it really has that feel. And at the end of every visit, especially on Zoom or FaceTime, where there are other family members there and you see the house, I always say to them, thanks for inviting me into your home. It's just it's a warmer thing. It kind of breaks down the barrier of doctor-patient. When you're seeing somebody in their home, it's more like person to person, I think. Yeah. It's a little more personal. Even it's funny because it's virtual, but it's a little more personable.
Yeah, yeah. So last question for you folks is this. If you had to wave a magic wand and change one more thing, what would it be? And we'll go to you first, Guy. To get people back to care for COVID, if you could add one more thing that you think would be successful that isn't out there yet, what would it be?
Oh, you caught me blindsided on that question.
Could be a
Uh,
mask mandate. It could be a stay at home.
yeah,
Could be, it could be, like you said, getting the ACS to invest in some national advertising to get people back to
or
care.
even I think that's really what it has to be, a little bit more, because it's been such a political issue, especially during the election. It's a political issue over competing healthcare ideas, and people staying lockdown versus no lockdown, states against states, who's doing this, who's doing that. And maybe it's starting with the local medical communities. We have Michigan State Medical Society.
Yep.
I haven't seen a letter from them. A lot of the medical associations are political too. So,
Yeah.
various people. But I think it really needs to come. We need to lobby a little bit.
Mark, you got about 10 seconds. We're running out of time. We're over.
Oh, no worries. Yeah, I think just taking a unified approach to really addressing the pandemic and would really help. Yeah.
Well, thank you both for your great insights into this important subject. Thank you to all the attendees. Thank you to Grid Health and all of the sponsors for having us. And I know you're already over time, so go to your next panel. Thank you, everyone. Have a great day.
Thanks for having us.